Welcome to Dr. Carol Goldberg and Company. I'm Dr. Carol Goldberg. My company, guests who are making a difference. What they say here could make a difference in your life. My guest today is Dr. Lisa Rappaport. Dr. Rappaport is a psychologist with a PhD from Fordham University. She has done research on attention deficit disorder and learning disabilities with the renowned pioneer Dr. Rosa Hagen. She is published on attention deficit disorder and is writing a book about learning disabilities. She is a psychologist at Einstein Medical Center and has a private practice in New York City. No doubt you know people with learning disabilities and attention deficit disorder. They are not mentally retarded. They have a normal level of intelligence. Yet they have learning difficulties in certain areas, unable to concentrate, and as a result have learning difficulties. Today we are going to discuss learning disabilities and what parents and professionals can do to help children who have such problems. Welcome, Dr. Rappaport.
Thank you. It's a
Pleased to
pleasure
have you here. Let's jump right in. What are some types of learning disabilities?
Well, the most common one is dyslexia, where children have trouble learning to read.
Okay, lexic meaning reading.
Right.
Okay, so they have trouble learning to read.
They have trouble learning to read. They have trouble making sense of the written word.
Okay, and what are some other types?
There's auditory processing difficulties. There are perceptual difficulties.
Okay, and for different subjects like dyscalculia, for people who have problems with math, there are different kinds of areas that
Sure.
they can have problems with. Okay. What are the causes of learning disabilities?
The cause is really neuropsychological. Children are just born that way. They're just wired differently. It's really an organic cause.
Okay, so it's something which is physically caused, it's neurological, okay, and the children who have these difficulties have them lifelong because they're born with them. Although they may have injuries or illnesses after birth.
That's a different type of learning disability, but yes.
Okay, well, we're doing the whole gamut.
The whole
of
gamut,
it.
sure. It can be an injury.
So there are children that could have injuries,
injury.
that have a traumatic brain injury, okay? And it's also because it's neurological, it's likely to be consistent in setting to setting, whereas we know if something is emotionally caused or related to being with other people, interpersonal, it will be different in different settings. These children have across the board problems in a particular area or in multiple areas. So in other words, a child who is dyslexic that has difficulty reading will have difficulty reading whether they're at the library, at home, in school, or on a bench in a park.
Exactly.
Okay. And also, it's not a conduct disorder. I want to make that clear to people that what we're talking about today when we talk about attention deficit disorders and children who are hyperactive, they're not conduct disorders. In other words, the child is not misbehaving. The child really has something neurologically that, as you said, keeps them wired and hyper or unable to concentrate.
Absolutely.
And unable to learn. 7% of American children have learning disabilities, but among teenage boys, which are the highest, is 12%. And we know that boys have double the amount of learning disabilities than girls have. Any idea why?
Years ago, it might have been because girls just weren't picked up as frequently. Same with attention deficit problems. Boys were just picked up more often, and girls manifested it differently.
Okay, in what way is it different? Can you give us some kind of
Girls
idea of that?
tend to, if they have an attention deficit, they tend to not have the hyperactivity part of the disability, whereas boys tend to be more hyperactive. No one knows why the boys...
Well, boys are more active anyway. If you
right.
look at children who are, the normal run of children, you will find, of course, that boys are much more physically active than girls at just about every age, and it may be hormonally based, testosterone, whatever.
Sure.
It's very possible. Any genetic factors in learning disabilities?
Yes, there's a genetic link. Usually through generations. If a parent is learning disabled, there's usually a child who is learning disabled in the family.
Okay, and that's often not picked up because years ago people didn't understand this, and therefore there are many parents who don't realize that they really had a learning disability when they were in school, and they're well functioning in other areas, and they get married and they have children, and then they find out that their child has some difficulties and the child is getting diagnosed, and all of a sudden they're asked by the professional, well, have you ever had problems like this?
Right, parents, back then, it wasn't as well known, it wasn't as well studied, and therefore there are a lot of parents that went without a diagnosis, but usually we pick it up when we talk to the parents about their own educational background.
I remember very specifically a number of times, but where I would see a family and the parents were very well functioning because they had compensated by that level of adulthood for their difficulties, but There were very subtle things that still remained. For instance, I remember one time somebody calling me outside my office when I had a private practice in Manhattan and saying, "How do I get to your office?" And it turned out he was right in front of the building calling from his cell phone. It turned out that the child also had some difficulties spatially and in orientation and things like that. And as we discussed it, the father said, yes, he had some problems as a child, but he was so brilliant in other areas that he got away with it, nobody noticed it, and nobody knew anything about it. So years ago, this wasn't really diagnosed.
Right, and teachers are much more in tune today to look out for things like that, for reading problems in children. They pick it up much earlier.
Okay, and again, we're not blaming the parents for any genetic factors, but simply that it might help in diagnosing it to know that. So sometimes if you can tell the professional that you're working with, gee, I had some problems with this also, it could be helpful. I know people who have children who have learning disabilities, and the parents had maybe a lisp or a spelling problem or something that was very subtle, and they were never labeled as learning disabled, and now that their children or grandchildren are having difficulties, they see that there is some genetic predisposition. How do you know if a child has a learning disability?
You go through a full battery of testing, and there are different parts of testing you would do.
Now you're talking what a psychologist does.
What a psychologist would do.
Okay, you as a psychologist do certain kinds of tests.
And you look for discrepancies.
Okay, well first I think you also would give a general intelligence test because we're ruling out that somebody has mental retardation.
Well, that's what I was just going to say. You look
Yes.
for discrepancies, so the first thing you do is give an intelligence test. And then you give educational testing depending upon the age of the child to see if there is a discrepancy at where the child is achieving academically and what the intellectual functioning is. Because obviously you would expect a child with average intelligence to be on grade level.
Okay, so these are children, and I want to emphasize this again because I did mention it at the beginning of the program. These children are not mentally retarded, because somebody who's mentally retarded has an across-the-board lower level of intelligence. These are people who have a normal level of intelligence, but specific problems in learning, which may be specific subjects, or it may be a few specific subjects.
And the other thing you would look for are some neuropsychological signs.
Okay, like what?
It depends on the age, but usually they have trouble with left-right orientation and discrimination.
Okay, and usually some of these signs disappear by the age of 7, so we don't want people in the audience to panic when kids have letter reversals and stuff.
Oh no, it's right. It depends on the age of the child. For small children, you would see if they have auditory discrimination abilities, if they can hear different sounds, if they can see different shapes oriented. But it is totally normal to reverse letters until about
like
the age of 6.
B's and
D's,
and
P's
particularly
and Q's.
in English, because there are some letters that are mirror images of other letters like B and D.
Right.
Something happens, I think, from the clinical practice that I had, that children around age 7 begin to organize neurologically differently, and they may outgrow some of these reversals by age 7. And after that, when they're 8, 9, 10, 11 and still have it, it becomes significant. Do you find that in your practice with children?
Absolutely, sure.
Many children seem unfocused and seem to be running around all the time. So it's estimated that anywhere between 1 and 20% of children, and that's a big range, I realize that, but between 1 and 20% of children are estimated to have attention deficit disorder, and many of these have it with hyperactivity. How do you know if a child has attention deficit disorder and has it with hyperactivity when children are, in general, unfocused, running around, active? How do you know?
2 things. First of all, it's very important to consider the age of the child, because up until the age of 9, children are hyper and running around, and it's pretty normal. So you wouldn't want to diagnose a child at a very young age. You want to make sure that the child is at an age where developmentally it's appropriate that the child would be able to sit still. And it also can't be situational. As you were saying, same with learning disabilities, it has to be global. If there are certain situations where a child actually can attend and sit, and that doesn't mean video games, but if it is situational, then usually it's not a pure ADHD, it's something that's going on with that child.
Okay, ADHD means attention deficit disorder with hyperactivity. Yeah. The AD is attention deficit disorder, ADD, and the ADHD is the hyperactive disorder.
Exactly.
Okay.
And there are certain children who may have trouble in a certain class or may not get along with that teacher, and then you have what you call situational ADHD, which would be that they are hyperactive in that situation, but it doesn't mean that there's something neurologically wrong. It means that they're frustrated, they can be depressed, there can be other things causing their behavior. So you have to tease out whether it's global or situational.
Okay. And sometimes the hyperactivity really is not that they run around more miles than other kids do, but just that they're unfocused, restless, unable to concentrate.
And disorganized.
Okay, the disorganized, I want to emphasize, is a very big part of it, because there are people that just have that one symptom, and it really is very difficult because they go through life losing things, being unable to be on time for places, appointments, and stuff like that. People who will travel around the world and lose their passport, inevitably. No matter where they go, they lose the passport. And some of these people are very disorganized. They lose things, they don't know where they put anything, and it's a very hard struggle for them. You know, you can tell them to make lists, you can tell them to compensate in many ways, but it's very hard because it is hardwired neurological.
Right, and for that, the intervention would be to work with them, and you might say to make a list, but you would have to demonstrate and really help walk them through things like that.
So let's just go through a few of these with attention deficit disorder, and I want to mention that before the hyperactive type.
Okay.
They would miss details, they would be disorganized, they don't have to have all these symptoms, but just to give a range for parents who may not realize what they're looking for, that they can't sustain attention, they don't seem to listen to you.
Right, they're distractible, very distractible.
They don't concentrate, they don't follow through. You tell them to do something and they just forgot what it was that they were supposed to do because they didn't hear it in the first place.
Right.
And I don't mean hearing from a hearing deficit, I mean that they didn't listen.
Process it.
They avoid tasks requiring concentration, so you may think that they're lazy or you may think that they're misbehaving, but it's really that they struggle and they can't do it and they're very frustrated and they may be forgetful. Okay. Then with the hyperactive type added to that, it would have the extra component of fidgeting,
Right.
of being unable to sit still, squirming, running around.
In school, it's a lot of out-of-seat behavior.
And interrupting and shouting out the answer to the question when the teacher's asking somebody else, being impatient, unable to do quiet work, to work by themselves, and also talking excessively can be a sign of it.
Sure, and just general disruption in school.
And there are other problems that go with the hyperactivity because these children run around and often get injured, and so they may have more broken bones, more injuries, and also peer rejection. You know, if you're not chosen to be on the team because you're not well coordinated and you're not organized, it can be a social rejection as well.
And they don't read social cues because they don't.
Explain what you mean by that. Because
they just, these children, as you said, they're very impulsive and therefore they don't sort of take in social cues that other children might. They may not read facial expressions as well, and they just have trouble in a situation, assessing a situation and then deciding how to behave. They're so impulsive that they don't think before they act, and it does make them unpopular in school.
The impulsivity is a very important thing for children to be able to master. It's one of the tasks of childhood and of later on, and these children really don't get it. They have a problem with it. I think some of the people may have seen a program that was on television that showed children who were about 4 or 5 years old and given some M&Ms and told to wait to eat the M&Ms, and they're sitting there squirming, and they're struggling, and they're just all over the place, miserable, don't know what to do. Some of them ate the M&Ms, some of them were able to wait, but the children who were able to wait, that kind of mastery over impulsivity, even at 4 and 5, predicted how they did later in life when they were adults. So it's a very important skill, and it's something that is very hard for people who do not have the neurological basis for doing it, the ability to do that. Most professionals, it seems, really prefer a coordinated team approach because there are so many different aspects, even if it is neurological. What is the most effective kind of approach? Let's go through some of the different aspects. For instance, educationally, what can be done educationally to help children with learning disabilities, and then also with the ADHD?
Well, it's different with learning disabilities. These children can learn. They just need to learn slowly, and they really need a solid phonetic approach if it's reading. But they need smaller classrooms, they need individual attention, they need things repeated, and they need to overlearn. Whatever they learn, they have to overlearn until it really becomes automatic for them.
They have to rehearse it and rehearse it. It's what you say, practice and practice and practice.
Exactly. And I usually go by a 3x3 rule. So
Tell us what that is.
They're learning something new, they have to have mastered it 3 times on 3 different occasions before it's considered really mastered, and then you can move on to the next thing. And it's very important because otherwise they tend to become confused if a new concept is introduced before the old concept is really mastered.
And also they need a lot of structure with taking away
That's
distractions.
why you want the smaller, well, that's for the ADHD. You would always want a smaller classroom, but especially for children with ADHD, it's good to sit in the front of the room in a smaller classroom where there won't be visual distractions or auditory distractions. You want the child to be able to focus and
provide them with a lot of structure that
course.
they can't provide for themselves.
And you want to organize everything for them, organize their desk, organize the classroom, organize, whatever they need to do, you need to help them, organize their homework, give them a homework pad, show them how to write it down. Really take them through step by step and don't assume that they can do anything by themselves until you've shown it and demonstrated for them.
It seems that there are different aspects of how the educators approach this that at some points in vogue. What do you think now is, helpful to children? Are there any fads or any kind of thing that's particularly helpful now educationally, like mainstreaming versus putting people in special classes? Do you have any opinions on that you'd like to share?
I think it depends on the child's disability as far as mainstreaming.
By mainstreaming, we mean putting children in a class with
in a regular class,
unselected. It's not for children who are in any particular category.
Right, and it would depend on how severe the disability is and how much help is available to the child outside of school or after school. So I don't go for fads. I was trained, as you said, by Rosa Hagen, who is an old-timer in this, and therefore a good basic phonetic approach is the way to remediate a learning disability.
Okay. What can be done psychologically to help these children?
Well, these children have experienced failure, and they know that they're different, and building self-esteem is critical. I like to see them in things like karate, where they're taught self-discipline, and it's also something that's competitive within yourself. Anyone else, you're trying to get to the next level, but it's all what you can do. So I like to absolutely build self-esteem in areas that they can, develop, and areas where they may already have a talent, like art, or anything that would be non-competitive, but where they would see results, or even competitive sports if they're good at that. But self-esteem is a very big issue for these kids, and they have to succeed somewhere.
You said competitive sports. How about Special Olympics and things like that? Do you think that is worthwhile for these children, or do you think it's counterproductive? Do you have any view of this?
I think Special Olympics would be more for children that are more disabled than learning disabled children.
Well, for clumsy, children who are not well coordinated and things like that they can be on a special team or something. Do you think that works well, or does it sort of force them to do something that's hard for them?
I think it depends on how competitive the team would be, but I think anything where they can sort of grow and learn sportsmanship and play on a team.
Socialization and
sure, it's very important.
Because team building, we use the word team building in corporations.
Yeah, it's very important.
So it's very important, and children do learn these skills through sports very often in terms of cooperation and competition.
And patience.
What about cognitive behavior therapy? Does that have any role here? In other words, for children to be able to get some control over the behavior by, learning certain kinds of tasks that they think about, changing their thoughts and their behavior?
Absolutely, especially, in the area of ADHD.
Yes.
Before they act, if they're taught, control, if they're taught to take a second and think about what they're going to say, or think before they react, if they can count to 10 before they blurt out an answer, it's absolutely effective, and it's definitely the way that we can help these children.
We see this sometimes, and the audience may be familiar with emotional intelligence because a psychologist, Dr. Dan Goleman, had written some books on it and popularized the concept. And some of these skills that you're mentioning, with being able to have impulse control, being able to delay gratification, really come under the title emotional intelligence. And it's known to people as street smarts, as being able to know how to negotiate and how to cope and how to do certain kinds of things with other people. So these are what you're mentioning.
Yes.
Okay. They even have this red light, yellow light, green light, where red light is to stop. Green light means you can go ahead, and yellow light means stop and think and wait.
And that would be the cognitive behavioral therapy.
That's why I mentioned it along with this. Okay. What can be done with medication? Because that's very controversial. There are many children who are medicated on things such as Ritalin and other type of stimulants. And I'm not going to ask about any specific kind of medication because medications change, and again, you're talking about fads, but how do you feel about young children being on medication, and is it overdone?
I definitely think it's overdone. And as I said before, children shouldn't even be diagnosed as ADHD before the age of 9. And there are...
You certainly wouldn't want nursery school children
No.
and kindergarten children to be on medication. Okay.
And there are certain children where medication can definitely help them. But as I said, it's a difficult to diagnose, and you want to make sure the diagnosis is proper. And for children who are truly ADHD, the medication will help them concentrate in school.
Now, sometimes the diagnosis is made too casually. It should be certainly a team-based approach with a psychologist, and we're talking about licensed people. So a licensed psychologist, school psychologist who has certification, a teacher. There are special ed teachers who are very good at knowing what these children are like, and a neurologist, pediatric neurologist, to be able to see whether there is something wrong beyond the ADHD that you're looking for, whether a child might have a brain tumor, might have some other kind of problem that is causing the behavior. So it's very important to do a thorough workup with a complete team that would include a psychologist, an educator, would include pediatrician, pediatric neurologist, people like this, right?
Absolutely. Especially because things like depression can mask ADHD. And a child who's very depressed may look like they have an attentional problem, but it's really depression.
That's interesting because depression in adults is very often with slowness and withdrawal and that kind of behavior rather than activity. But children who have ADHD, who are hyperactive, can be depressed.
Sure.
And to be able to see which are depressed, which aren't, and also the depression in children can be they're running around and being irritable.
Right, and distractible and impulsive.
And angry. So it's very hard. You have to have somebody who really is experienced with these kind of problems, not just any psychologist or any neurologist, but people
Right.
who are specialized in these problems. It's interesting also that they're given stimulants which slow them down, and supposedly the idea is that the stimulant is stimulating or arousing part of the brain that is too sluggish, and so it's enabling them to have control.
It actually helps them filter. It gives them the filter that the rest of us normally have, and it helps them filter out some of the things that would actually cause distractibility.
And also when we think about medication, we have to think about whether there are short-term effects, long-term side effects, and also whether these things are addictive or not.
And it comes out of your system within 4 to 5 hours, so I don't know that it's addictive, but there are children who might have a tendency to have Tourette syndrome, and for those children there are these medications that might bring out tics, and that is important to think about before putting a child on Ritalin.
Okay. What happens when these children grow up?
Well, they become those forgetful adults that you were talking about.
Okay. But they are less hyperactive.
The hyperactivity seems to go away, or they tend to pick professions like trading where they can be on the ball and they can, there's a lot going on and it's stimulating for them. So they pick stimulating professions.
Where they don't have to sit in a chair.
Right.
Okay, well, we take an email question from a viewer. A viewer asks, excuse me, some kids make fun of those with disabilities, but even kids who want to be nice often don't know what to say or do. How can we teach them? Unfortunately, many adults also feel awkward about disabilities, and adults need to be role models for children to learn from them. If you're respectful to people who have disabilities, your children will copy your respectfulness. Visible disabilities are easier for the public to deal with because they can see them, and because the person who has a visible disability might be willing to discuss it openly. Invisible disabilities, though, also require sensitivity. Instead of assuming someone's lazy, be patient so your child can copy your patience. Don't overprotect those with disabilities. If offering assistance crossing the street to a person with blindness, ask whether help is wanted. And if so, do it. But don't be offended if they don't want your help. If your offer is accepted, let the person hold on to your arm and give around obstacles. You can also assist without calling attention to disabilities. For example, instead of shouting at people who have deafness, face them directly because they may be able to lip read, and speak slowly and clearly so they may be able to follow what you're saying. When talking at length to a person who uses a wheelchair, instead of having them crane their neck to talk to you, come down to their level, sit or kneel, so that they can talk to you without straining their necks. Try to watch your language. People prefer to be described as having a problem, not being the problem. If you've ever been hospitalized, you know how annoying it is to be referred to as the appendix in room 212. And don't assume that everyone likes the same language. Take the cue from their preferences. For instance, the term disability is more positive than handicapped. However, people may not be comfortable with terms such as physically challenged or differently abled. So listen to what they say and try to use their language. It might be quite individual and personalized. Go beyond disabilities with focus on abilities. For instance, if your child refers to a classmate as the boy who limps, ask about his other characteristics. Then replace the original description with, "Oh, you mean Michael? Michael who's in your class, the one who's a computer whiz and has a great sense of humor." Perhaps Michael could help your child learn a computer program, which encourages companionship as well as respect for Michael, and will help Michael's self-esteem too. Go further. Volunteer with your children to help out at an agency for people with disabilities. Not only will you be helping those with disabilities, but enriching your child's life with valuable lessons. A bit about myself. I'm a licensed psychologist, board certified in clinical psychology by the American Board of Professional Psychology, and earned a PhD from Columbia University. I'm founder and president of Getting Ahead Programs. My experience in psychology, education, and business is with all types of people of all ages. Rather than work with mental illness as some psychologists do, I focus upon promoting health and productivity in the general population. I specialize in helping people manage stress, have healthy lifestyles, and achieve their goals, and motivating them to do that. In order to reach many people, I speak at corporations, conferences, and associations, as well as in the media. I also teach people to speak comfortably to audiences and the media. Further information is available on my website. You may want to grab a pencil and write down the address, www.drcarolgoldberg.com. You can go to our website, find out more about our program, find out more about us, find out and contact me and my guests, send us comments, send a topic for a future program. Send us an email question that we may answer on air. We can't guarantee to answer all of your questions, but we will take questions, and yours may be among those that we answer. At this point, I would like to thank Dr. Rappaport for being on our program and for sharing some insights about how we can help children with learning disabilities and ADD to straighten out some of these topics, these questions, and also to be able to give some advice to parents and educators. And thank you very much.
Pleasure.
At this point, we're going to show our audience something about our show. We're going to show the disclaimer credits and thank them very much for coming today to listen to our program, and we hope you will come again and listen to our program in future programs. Thank you.